Friends, it's a pleasure to be here and thank you for the invite to talk on diabetes, thyroid, crosstalk. This is a very important topic because both thyroid diseases like hypothyroidism and type 2 diabetes are both very common in India. This is the 8 city study on hypothyroidism, and interestingly, why I show this data is because diabetes as well as thyroid diseases were measured in the same population. This was done in 8 urban cities of India, and the total number sampled was 5376. You can see that hypothyroidism was seen in 3.47%, overt hypothyroidism, undetected overt hypothyroidism, subclinical hypothyroidism in about 8%, hyperthyroidism in 0.6%, and so on. But diabetes was seen in 16.6%, showing you that diabetes is very common and thyroid diseases like hypothyroidism are also common. Very importantly, certain features of primary hypothyroidism are also similar to the features of metabolic syndrome. Primary hypothyroidism people gain weight, they have dyslipidemia, they have insulin resistance, hypertension, they have an increased risk of NAFLD, non-alcoholic fatty liver disease, and they have high CV risk. And remember, metabolic syndrome also has the same factors. These are the metabolic changes and glycemic control in people with type 2 diabetes. This is a busy slide, but I'll just request you to focus on this area. Whenever there is hyperthyroidism, there is an increased apoptosis of insulin producing cells. This results in hyperglycemia. But there is an increase in insulin clearance which can worsen hyperglycemia. There can be ketoacidosis, and in diabetes patients with hyperthyroidism, the insulin dose may go up. On the other hand, if you look at hypothyroidism, there is a decrease in the renal clearance of insulin. The requirement of exogenous insulin comes down. There is increased risk of hypoglycemic episodes in people with diabetes who have hypothyroidism. In diabetes people, the insulin dose comes down. And once you give thyroxine to a hypothyroid person with diabetes, you might require to increase the insulin dose. So to summarize this slide, what is important is that in hyperthyroidism, there is a tendency to hyperglycemia, and in hypothyroidism, there is a tendency to lowering of blood glucose levels. So there's a lot of interest in type 2 diabetes and also thyroid cancer. Some studies have shown that thyroid cancer increases, the thyroid swelling increases, and that metformin can reduce it, so on and so forth. But this is not proven. In fact, this is one of the largest studies. 147934 women who were free of known cancer at baseline studied prospectively a median follow-up of 15.9 years. They found 391 incident thyroid cancers. And interestingly, the authors found no significant association between thyroid cancer and diabetes. The hazard ratio was 1.09, so right at 1. And also, there was no association between thyroid cancer and diabetes treatment or thyroid cancer and duration of diabetes. So that probably lays to rest all these theories that thyroid cancer is associated with diabetes. Now, if you have a person with diabetes, type 1 or type 2, what do the guidelines say about thyroid function testing? This is a combination of all the guidelines, the American Diabetes Association guidelines, the AAC guidelines, and other guidelines. So I've tried to combine them. And what the guidelines say is that in type 1 diabetes, the TSH and TPO antibodies must be screened at baseline and then annually. In people with type 1 diabetes, you may need to screen for hypothyroidism more frequently if the person has a goiter, or if the GAD antibody is positive, or if the child fails to grow or has pubertal problems, or if the glucose levels fluctuate. So these are some of the indications where in type 1 diabetes, you might like to screen for thyroid disease a little more aggressively. So in type 2 diabetes, look, type 2 diabetes is a common disease. Hypothyroidism is a common disease. So the association between hypothyroidism and type 2 diabetes is not an etiological one. It's an association of chance. So both can coexist. So there's no need to repeatedly test for thyroid function in diabetes as such. And no need for routine calcitonin tests with GLP-1 receptor agonists as such. But I just want to highlight that in type 2 diabetes, do not specifically check for hypothyroidism, but if there is a reason to check for hypothyroidism, like if there is weight gain, or subject is planning pregnancy, or if there is constipation, or there's a goiter, only then you should check. So the guidelines are very clear. In type 1 diabetes, check thyroid function tests and TPO baseline and annually. More frequently if there is goiter, GAD65 antibody, growth issues, and glucose fluxes. And TSH should be done at a baseline in type 2 diabetes, but repeated testing is not really required. Now, I'd like to talk about three areas because we all know the basics of diabetes, thyroid, crosstalk. I wanted to bring something new to this discussion, so let me talk about three new areas. One is monogenic diabetes or maturity onset diabetes of young and thyroid cancer. Now, very importantly, maturity onset diabetes of young, monogenic diabetes can be of several types. Now, mutations in the hepatocyte nuclear factor 1 alpha or hepatocyte nuclear factor 1 beta genes are responsible for MODY type 3 and MODY type 5 respectively. But interestingly, or rather importantly, it's not interesting, it's important from the patient perspective, is that the first one, that is HNF1 alpha, both HNF1 alpha mRNA and protein have been detected in anaplastic thyroid cell lines. So HNF1 alpha, which is associated with MODY3, has been detected. The mRNA and protein have been detected in anaplastic thyroid cancer cell lines. And HNF1 beta, which is associated with MODY5, has been expressed in papillary cancer cell lines where there is a high nicotinamide N-methyltransferase gene expression. So what is the clinical significance of this? Well, we don't know the clinical significance of this, but I'd like to say that further studies on the function of HNF1 alpha and HNF1 beta in thyroid cancer cells should be performed to individualize molecular targeted therapy in future. So this could be one of the ways in which we can look at more precise treatment of diabetes as well as thyroid disease. And also I wanted to highlight this not very well known crosstalk between maturity onset diabetes of young and thyroid cancer. So I've looked at the first part, maturity onset diabetes of young, and those little genes which are also expressed in thyroid cancer cell lines. I want to talk about the next one, is that type 1 diabetes masks the diagnosis of thyroid disease. So here's a 13-year-old girl with type 1 diabetes and a diagnosis. The HbA1c is 13.5%. The random blood sugar is 456 milligram per deciliter of the random blood glucose. The GAD65 antibody, which is an index of islet autoimmunity, is also positive. The TSH in this 13-year-old girl is 0.54, the free T4 is 0.78, and the TPO is positive. I want you to look at this case a little more carefully because whenever there is hyperglycemia, that suppresses the hypothalamo-pituitary axis, and that might suppress the TSH and free T4 and mask hypothyroidism. So it's important that after a while you recheck the thyroid function. And this slide shows the spectrum of thyroid abnormalities in type 1 diabetes. One is, of course, delayed diagnosis because some of the symptoms like weight gain in hypothyroidism are masked by type 1 diabetes, which results in weight loss and osmotic symptoms. Now, there is a low T3, but not so low T4 in type 1 diabetes people naturally. And that's because of their initial diagnostic hyperglycemia the T4 to T3 conversion is affected, especially in diabetic ketoacidosis, and therefore they may have a low T3. So that may be a phenomenon. Another finding is that thyroid hormone binding inhibitor THBI, which is an inhibitor of the extrathyroidal conversion enzyme 5-dehydrogenase, which converts T4 to T3. So when the thyroid hormone binding inhibitor is present, T4 to T3 conversion is blocked, and again you have a low T3 and a not so low T4, or even a normal T4. So remember, in type 1 diabetes, there's no point in really doing T3 unless you're suspecting thyroid toxicosis. If you're suspecting hypothyroidism, just do a T4 and TSH. Finally, hypothalamo-pituitary thyroid axis suppression. Hyperglycemia and stress can also reduce the TRH, TSH, and also the thyroid hormones. So coming back to this 13-year-old girl with type 1 diabetes, once you've managed the hyperglycemia, I think it's very, very important that you retest for thyroid functions. So we know that in the landmark studies of TPO, people with TPO had a 2 to 3-fold higher chance of progression from subclinical to overt hypothyroidism. This is very similar data but done in type 1 diabetes. In fact, this is the DCCT cohort, the Diabetes Control and Complications Trial, which was a premier trial done on type 1 diabetes and showed that glucose control helps. Now, in this DCCT cohort subjects, as you can see in the x-axis, you have the duration of diabetes, and in the y-axis, you have the percentage of people without hypothyroidism. You can see that if the TPO is negative, there is a higher percentage of people without hypothyroidism, and if the TPO is positive, there is a much, much lower percentage of people who are free of hypothyroidism. In other words, TPO positivity predicts hypothyroidism. But unlike in the adult population, in the DCCT type 1 diabetes, the association between TPO and eventual hypothyroidism was very strong. In fact, people with type 1 diabetes who were TPO positive were 17.91 times as highly likely to develop hypothyroidism compared to people who are TPO negative. And this was over a follow-up of 18 years. And the study also found that hypothyroidism was commoner in women than men. This was a little paper we published. We looked at a very unique test, and this is in 2006. We studied TSH receptor antibodies in people with type 1 diabetes, and this was one of the authors was Dr. Sanjeevi from the Karolinska Institute in Sweden, and we found that 18% of type 1 diabetes people had TSH receptor antibody positive. And we also found that the TPO and TSH receptor antibodies identify two different subsets of people. And therefore, if you look at TSH receptor antibody measurement in type 1 diabetes, you may increase the pickup of autoimmune thyroid disease. Remember, TSH receptor antibodies do not really tell you whether the antibody is stimulating or blocking. If the antibody is stimulating, it produces hyperthyroidism. If it is blocking, it produces hypothyroidism. So therefore, this test does not tell you whether it's a stimulating or blocking type. But yes, this may be an additional test. But having said that, this study I did in 2006. After that, not many studies have even looked at or confirmed these findings. So I urge you to take this result with a pinch of salt or even a pinch of sugar as we are talking about diabetes. So I'm not really convinced with this data, but this is something which we can do further research on. Finally, I've looked at MODY and thyroid cancer. I've looked at how type 1 diabetes masks diagnosis of thyroid disease. Let's look at insulin sensitizers and the thyroid. Now, this is a retrospective study done on 393 euthyroid diabetes people and divided them into three groups. One group never received metformin and levothyroxine. In that group, you can see the bar graphs on your extreme left, M minus, L minus, and at baseline and at the end, the TSH remains a little similar. Maybe the TSH goes up a little bit. In the other two groups, one group, they had only metformin, 203 subjects, only metformin. no levothyroxine, M plus and L minus. And in the third group, they gave both metformin and levothyroxine. What is interesting is, in the groups where metformin was given, whether they received levothyroxine or not, the TSH came down. This is a very interesting paper because it shows that metformin can actually reduce the TSH. And therefore, the authors did a multiple regression analysis for TSH serum levels at 1 year of follow-up as a dependent variable in the whole group of euthyroid diabetes people. And as you can see, the p-value was 0.031, and that showed that metformin was a significant factor in lowering the TSH. So therefore, metformin lowers TSH. Metformin can reversibly lower TSH if TSH is about 2.5 and also in hypothyroid diabetes. Now, how does metformin lower the TSH? That's very interesting because we don't know the exact reason why metformin lowers the TSH. Initially, some people thought that metformin increases the absorption of thyroxine, but that theory has been disproven. Now, the favored theory is that metformin crosses the blood-brain barrier, acts centrally, and metformin suppresses the stimulation of TSH production via, in the hypothalamus, TRH is produced, thyrotropin releasing hormone or TSH releasing hormone, that stimulates the pituitary to produce TSH. Now, metformin blocks the release of TSH from the pituitary. There are other theories also that metformin makes TSH work better because of the IRS1 pathway, and therefore by its overlap with the insulin sensitizing pathway, and therefore the body has to produce less TSH. So, but important to note that metformin may cause a slight decrease in TSH, and this you may have to watch out for. This is another area which we don't traditionally think about, is that pioglitazone. Whenever we see people on pioglitazone, we also always look at their face and we find their eyes are a little puffy. But we know that whenever there is thyroid toxicosis due to Graves' disease and orbitopathy, we also know that this can cause protrusion of the eyes. But what is important is that in people who have Graves' orbitopathy and type 2 diabetes, when they were treated with pioglitazone or thiazolidinediones, that caused a worsening of Graves' orbitopathy without any changes in thyroid hormone levels. And once the pioglitazone worsened the orbitopathy, removing the pioglitazone did not help. So friends, remember, let's not prescribe pioglitazone in thyroid orbitopathy. Now, we know that pioglitazone acts via the PPAR gamma pathway, and the expression of PPAR gamma is greater in the adipose and connective tissue from patients during the active stages of Graves' orbitopathy in the eye. The activation of PPAR gamma by thiazolidinedione stimulates functional TSH receptor expression. And we know that if there are more TSH receptors, the binding of TSH receptor antibody will increase in the eyes, and therefore it may worsen orbitopathy. Pioglitazone also increases the recruitment and differentiation of orbital fibroblasts into mature lipid-laden adipocytes. And therefore, the activation of PPAR gamma may play an important role in the stimulation of adipogenesis and the pathogenesis of Graves' disease induced by thiazolidinediones. So this is a published case study where you can see that the patient previous to initiation of thiazolidinediones on the left, and you can see serial photographs that once pioglitazone was started, thiazolidinediones was started, patients' eyelid retraction and proptosis worsened, and as I said, it may not get better once you stop the drug also. You can also see the magnetic resonance image scans of the patient on the right, showing expansion of the orbital fat compartment and enlargement of the rectus muscle, showing that yes, let's not give pioglitazone if we have a patient with thyrotoxicosis and diabetes. Well, I've looked at several aspects of thyroid disease. I talked about how common the association between thyroid disease and diabetes is. I looked at the unique problem of thyroid disease in type 1 diabetes and of course in type 2 diabetes as well. I also looked at how metformin may lower the TSH. I looked at pioglitazone and orbitopathy. And I also looked at certain other aspects like MODY and certain MODY genes may be also overexpressed in thyroid cancer cell lines. And I also looked at how thyroid disease may be masked in type 1 diabetes. Thank you so much for listening to me. It's a pleasure talking to you. Thank you very much.